Good evening, doctors, and welcome to the Quirón Salud Masterclass. Today we have the pleasure to introduce you Dr. Antonio Berruezo. Dr. Berruezo is one of the most experienced arrhythmia specialists in interventional treatment of cardiac arrhythmia. He's also renowned for his work in the prevention and treatment of sudden death and pacemaker and defibrillator implantation. Dr. Berruezo is currently a member of the small group of specialists in charge of writing cardiac arrhythmia treatment guidelines for American, European, and Asian scientific societies. He leads international courses on treatment techniques through ablation and arrhythmia, which causes sudden death, and he has written over 200 research articles in the most prestigious international journals. 3 quick instructions for you, doctors. The questions to Dr. Berruezo can be typed in the questions and answer box. Some questions will be answered by the doctor at the end of the session, and the certificate of attendance can be collected at the end of the session. Please, Dr. Berruezo, you can proceed to present the webinar. Thank you very much.
Thank you, Carlos. It is a pleasure to me to be here and to contribute with this speech to the Waterfall project. And I'm really happy speaking about that because this is one of the main focus of the research we are doing here in Teknon Medical Center during the last 2 years. All this research we have done is to develop a way of doing atrial fibrillation ablation in a personalized fashion for every single patient. So this is our approach. These are my conflicts of interest. First of all, I want to say that here in Teknon we are not a small, we are maybe a medium-sized hospital, but we are very active and we are a high-volume center in terms of electrophysiological procedures and specifically ablations. So we are doing about 1,500 ablations per year. Atrial fibrillation represents about 50% of all cardiac ablations we perform here in Teknon, which is approximately the mean of the most developed countries in Europe. And with respect to atrial fibrillation ablation, the majority of ablations are done by means of radiofrequency. Cryoablation of atrial fibrillation represents here only about 15% of the cases. And the majority of the cases we do in AF ablation are paroxysmal. Only about 25% are persistent atrial fibrillation cases. So when we perform by means of radiofrequency ablation and atrial fibrillation ablation, there are 2 things which are the most important things. One is that the ablation line that we perform to isolate pulmonary veins should be a continuous line, so continuity is very important. And the other important thing is that the lesion we produce with the radiofrequency ablation delivered by the catheter at each single point should produce an enough volume of lesion in the atrial tissue to be a durable lesion. So it is not only important that the distance between the different points would be short enough to be sure that we will not have gaps in this ablation line, but also that the lesion that we produce is durable in time. So we can isolate pulmonary veins to treat atrial fibrillation during the acute procedure, and then after months, if the lesion is not durable, it has not volume enough, the conduction through this lesion can recover, and then we will have recurrences. To be sure that we are doing a volume enough of lesion in the left atrial wall, we control different parameters. For instance, the time, the seconds that we are doing the ablation, the power, the temperature, the impedance and impedance decrease, and the force we are doing in each one of the applications with the ablation catheter. All of these parameters give us an index which is called ablation index. That is, if is rich or is enough, this will ensure that the lesion durability will be enough to decrease the recurrence rate during the follow-up of patients. This has been compared, and you can see here in these survival curves after atrial fibrillation ablation. Recurrence is higher when we do not use this ablation index. But there is something that we don't know. What we don't know exactly is the thickness of the left atrial wall that is different from patient to patient and is different also depending on the location that we are measuring. So as you can read here, left atrial wall is a thin structure with heterogeneous thickness that range from less than 1 millimeter, as you can see here in these arrows, to more than 5 millimeters, and has an important inter and intra-patient variability. Correct dosing of radiofrequency energy has obvious limitations without knowing the thickness of the underlying tissue. So we will need a higher volume of lesion with using higher ablation index when we have a more than 5 millimeters thickness as compared when we have a very thin site at the left atrial wall. First pass pulmonary vein isolation is limited by the inability to create transmural lesions in anatomical sites where atrial thickness is higher. This has been already demonstrated. So here you will see what is our protocol in Teknon Medical Center. This is the protocol that we call ablation by law, which is ablation by left atrial wall or left atrial wall thickness. That is a very personalized approach for atrial fibrillation ablation. So before ablation, we clearly define the type of atrial fibrillation, paroxysmal, persistent, long-lasting persistent, and we perform ablations always under uninterrupted oral anticoagulation. We always perform atrial fibrillation ablation under general anesthesia, controlling the ventilation with high rate, low volume ventilation, which is adapted to each one of the patients. So this is also a way to personalize the procedure, and with invasive hemodynamic monitoring, taking or controlling the arterial pressure by a radial artery. We always obtain a multi-detector CT scan before the procedure, which is something which is easily available and very fast to be obtained. And always the transeptal puncture is done under transesophageal monitoring. So we do ablations by a single catheter approach in first AF ablations, but also in redo procedures. And we adapt the ablation index to the left atrial wall thickness that we obtain from the information of the multi-detector CT scan. After ablation, we maintain the patient 6 hours with inguinal compression bandage. Then we perform a transthoracic echo 4 hours after sheet removal. And then, if all is correct, there is no pericardial effusion, we initiate oral anticoagulation after checking with the transthoracic echocardiogram. So the most important things to say that ablation is personalized is the fact that we perform an adaptation, or we adapt the ablation index to the left atrial wall thickness. For us, the most important thing is safety, is always our #1 priority. And in addition, we do all the procedures under general anesthesia with high rate, low volume, as you will see now. Okay, here you can see an example of a CT scan, which is always obtained 1 or 2 days, the same day of the intervention, or maybe 24 to 48 hours before the procedure. On the right, you can see the 3D reconstruction. On the left, you can see, as you can identify, the wall thickness from a simple CT scan that is post-process before doing the intervention, and then is integrated into the navigation system. The CT scan is easy to implement in the majority of centers. The acquisition is very fast, less than 5 minutes, and is also, differently from the MRI, is suitable for pacemaker carriers or any patient with ICD, pacemaker, or intracardiac electronic devices. So with respect to general anesthesia and mechanical ventilation, there are publications showing that the recurrence rate after ablation is higher when you use conscious sedation as compared with general anesthesia. This has been proved in randomized controlled trials. And also, there are some publications showing that when you compare AF ablations which are done both under general anesthesia, the use of jet ventilation as compared with traditional ventilation, all patients under general anesthesia, you are able to reduce recurrences during follow-up. So in this non-randomized trial, comparing traditional versus jet ventilation, which is super high rate, super low volume ventilation, recurrence rate is lower using jet ventilation, and in multivariate analysis, this is clearly the most important factor related with this reduction in the outcomes or improvement in outcomes during follow-up. So, but not only is important to reduce outcomes, but also to have an impact in the efficiency of the procedure. By using high-frequency, low-volume anesthesia, you are usually able to reduce ablation time, procedure time, and fluoroscopy time. And the reason for needs less requirements during the procedure is that by controlling the ventilation and using, as compared with traditional ventilation, using high frequency, low volume, you will have much more catheter stability. And this will directly impact in the movement of the catheter, the position of the catheter to map the left atrium, and especially for delivering radiofrequency. So the impact, the most important impact, is always related with the time of radiofrequency needed to obtain isolation of each pair of veins. So high frequency, low volume ventilation can be done in every single hospital. So regular ventilation machines are able to permit to do high frequency, low volume. You have to know that high frequency is considered when you use more than 40 respirations per minute instead of jet ventilations, which is super high frequency, super low volume, and you need special machines, special software. But high frequency, low volume can be used and can be implemented nearly in every single hospital. Here an example to see an example of the more or frequent parameters we use. You can see here that the tidal volume is about 200, 250. Ventilation frequency in this case was around 60 ventilations per minute. And this usually has no impact in hypercapnia, in producing hypercapnia. Or if we have a small hypercapnia, we call that this is permissive hypercapnia because it has no impact in the patient. And until now, no single patient has had any symptom after the procedure or any complication related with using this kind of procedure. Here, you can see an example on the rate, typical rate of ventilation that we use. And this is a view of the left atrium, which is observed like if you were in the ventricle. This is the mitral annulus. You don't see here the left atrial appendage because it's cut. This is the left pulmonary veins. Sorry. Okay. This is the inferior left, and this is the superior left. And here you can see, I'm sure you are not accustomed to see that the catheter has so high level of stability. So the color codification, you are not familiar with that because I'm going to explain that for you to be interpreted. But you can see the most important thing here is that you see how the catheter stability is increased to be so stable like that. So this is very, very different, believe me, as compared when you use about 15 respirations per minute during conscious sedation. Okay, the other important thing with the protocol we use here is the thing that we are using a single catheter technique. So we do all the procedure with a single venous puncture. This has a direct impact in the vascular access complication rate. In fact, we are having very close, very, very, very close to 0% complication rate. You need to do only a single transeptal access, and you have to manipulate catheters into the left atrium with a single catheter. So the time of manipulation, the need for fluoroscopy, and the complication risk due to manipulation of catheters in the left atrium will be also impacted. And in fact, you will see now, as with a single catheter can be, the block of the pulmonary veins can be perfectly seen. Here an example on how we do the transeptal access, which is guided always by a transesophageal echo. So we do a single venous puncture to introduce the catheter. We don't do another one to put an intracardiac echo to check for complications or to guide the transeptal access. We do that because the patient is already intubated. We use a transesophageal echo. Okay. So, and this is to explain you how we implement the measurements of the left atrial wall thickness to be used to guide the ablation procedure. So we do first the acquisition of the CT scan. We do a post-processing with the ADAS post-processing platform or imaging platform, and then we export the information and introduce this information into the Carto3 navigation system. So left atrial wall thickness is the distance between each endocardial point to the epicardial cell, and we usually can have information this way or this other way. Here the information is a binarization of color to better decide if here in red you have to apply one ablation index and in yellow another one. So transition is much more abrupt here, but helps to decide, to better decide in what place you have to apply one or other ablation index. So this 3D color shell is imported into the Carto3, and here this is the color codification. Less than 1 millimeter wall thickness in red, between 1 and 2 millimeters in yellow, between 2 and 3 millimeters in green, between 3 and 4 millimeters in blue, and more than 4 millimeters in pink. Okay, this is in general the pipeline. Obtention of the multi-detector CT scan and segmentation and calculation of the left atrial wall thickness in these images. Second, the obtention of the left atrial wall thickness 3D map. Third, we obtain an anatomical and electroanatomical map of the left atrium, and we merge this information with the information of the CT scan, properly color-coded depending on the left atrial wall thickness at every single point. Then we use that to target each one of the sites with an ablation index which is adapted to a each one of the sites, which is color-coded depending on the left atrial wall thickness. Okay, we use typically 35 bats for the posterior wall and 40 bats or 50 bats in the anterior wall, depending on the left atrial wall thickness. Sorry. Okay, so it is permitted between green and pink colors to use 50 bats to easily obtain the desired ablation index for each one of the wall thickness at every single point. Okay, so we apply 300 ablation index when we have less than 1 millimeter wall thickness, 350 when we have yellow, 400 when we have green, 450 when we have blue, and 500 when we have more than 5 millimeters. Here you can see an example of a patient with a very thick left atrium. We have observed that in patients with hypertrophic cardiomyopathy and also in patients with amyloidosis. But there is a lot of variability on the thickness of the left atrial wall between patient to patient, even if they do not have hypertrophic cardiomyopathy or even if they do not have amyloidosis. There is a lot of variation. This is because in the way of using that, we are really convinced time to time that this is very important and that we have to use very different left atrial ablation index for every patient because there is really different left atrial wall thickness for each one of them. Now you will see an example of a patient with a very thin left atrium. Remember this image and compare with this one. This belongs to a woman, medium-aged woman, with a left atrium, which is color-coded depending on the wall thickness at each side. And you can see here that the color codification is completely different as compared with the previous patient. The majority of the left atrium is red color and yellow color. So application of ablation index will be specifically directed to this wall thickness, and ablation for sure will take much less time as compared with the other patient. And this is very important because it is not only important to be sure that we increase the ablation index in thicker regions to avoid recurrences, but also that you do applications that deliver no more radiofrequency than needed, because you have also the risk to damage structures which are surrounding the left atrium, as the phrenic nerve, the esophagus, etc. So here you can see an example on how we tailor the delivery of radiofrequency to obtain the ablation index desired. Here, for instance, you can see that we needed 17 seconds applying 40 bats with about 30 degrees as maximum with this decrease on impedance, and the ablation index, as the color indicate here, needed to be around 350. If you can look at here, we needed, or it is recommended at this site in which we are applying radiofrequency at a site which is touching a zone with green color, the ablation index we apply is a bit higher than 400. As compared with this patient with a very thin left atrium, in which ablation index is close at this site to 300 and here to 350. But it is not only important, when you use imaging, you should take advantage of every single information that anatomy is giving you. Here, this is a tool that we are using now, which is that we call the fingerprinted esophagus distance to the left atrium. This is the esophagus of this patient, you can see here, and you can see the projection of the esophagus in the posterior left atrium. You can see if the esophagus is in the center of the left atrium or is close to any one of the ablation lines we are deploying. If you do ablation at this white line, you are far from the esophagus. If the fingerprinted distance is close to the ablation line, maybe you can have complications producing different types of thermal lesions in the esophagus, even an atrioesophageal fistula, which is a very severe complication. So we color code this distance. So by looking at that, you not only see the trajectory of the esophagus, if the esophagus is center, is located on the left, is located on the right, and the trajectory, but also the distance from the esophagus to the left atrial wall. If you look at that and you see red color, it means that the distance between the esophagus and the left atrial wall, the posterior left atrial wall, is less than 1 millimeter. If you see yellow, the distance is between 1 and 2. If you see green, the distance is between 2 and 3. If you see blue, the distance is between 3 and 4 millimeters. So important information. Here you can see an example on how we modify the trajectory of the ablation line to try to avoid to pass through the zone in which the fingerprinted distance of the esophagus to the left atrial posterior wall is less than 1 millimeter. If you don't see that, the deployment of the line could be here, but by looking at that, you change the trajectory of the ablation lane to try to do or to perform safer procedures because you are applying not very close to the esophagus. Here an example to explain you how this information is important. If you have this information that could be obtained from the CT scan, it is important and complementary to the information that you can have with the temperature proof. The temperature proof is very thin, and usually it does not indicate the exact position of the esophagus, because you can be doing radiofrequency ablation here and you have the temperature proof located very far inside the esophagus, but very far from the site where you are doing the radiofrequency applications. However, if you have this information, you have two things to be taken into account, not only the temperature proof, but also the trajectory and the distance from the esophagus to the posterior left atrium. Here an example on how we control that with help of the UniView module of the Carto 3. Okay, we are doing already the awesome trial, which is testing the usefulness of this tool and the impact in having problems with thermal lesions with the esophagus, and the impact that the modification of this ablation line can have in the outcomes during follow-up after atrial fibrillation ablation. Okay, left atrial wall thickness is of use also, have we seen, in redo procedures, because usually the connection between the left atrium, the left atrial body, and the pulmonary veins during follow-up is present at the thicker sites by looking at the ablation line. As you can see, the connection in this case was here, and here you can see that you have blue color. That means that we have more than 3 millimeters thickness at this point. So this can facilitate mapping of gaps into the circle we do around the pulmonary veins. Okay, this is an example of a patient with a left atrial flutter, which is using the left atrial roof and circulating around the posterior wall in a descending way. Now it's going up and then again to the posterior wall with this loop. If you look at the left atrial wall thickness map, which is obtained blinded to the information of the left atrial flutter, you can see if you are planning to draw a line in the posterior wall, probably the best site to deploy the line is here, because you have the shortest possible line between two sides with a wall thickness of less than 1 millimeter. And this is exactly what we did here, and this was very easy, because with 5 radiofrequency applications, we close the pass of this left atrial flutter, as you will see here in this movie. So the information of the left atrial wall thickness could be not only important for atrial fibrillation, for paroxysmal atrial fibrillation ablation, but also for persistent atrial fibrillation ablation, and can give us important information on how or where to deploy lines to treat left atrial flutters. This is something that this information that we are collecting now. I'm going to briefly explain the study we are doing, which is the Ablate by Law study. Here you can have the methods. So this is a prospective multi-center study looking for the feasibility, efficacy, efficiency, and safety of adapting ablation index to the left atrial wall thickness. People included have more than 18 years, an indication for paroxysmal atrial fibrillation ablation. We obtain a pre-procedure scan, which is post-processed with the ADAS 3D post-processing platform. We measure the left atrial wall thickness here with this software, and then we introduce this information in the Cartos 3 system. This is a procedure which is a single catheter echo-guided transeptal puncture, and which is performed under general anesthesia with high frequency, low volume ventilation. And the ablation index, which is adapted depending on the color codification of the left atrial wall thickness. Okay, here, this is the characteristics of the Ablate by Law single center study that we have done here in Teknon Medical Center, and that will be translated to a multi-center study. But this is information of the first prospective single center study, the single center Ablate by Law study, which is compared with the closed protocol, because the closed protocol is the protocol that have demonstrated the higher, in terms of radiofrequency ablation of paroxysmal AF, the higher efficiency, at the same time with the higher lesion durability. Okay? So if we compare age, the proportion of males, body mass index, arterial hypertension, structural heart disease, chest VAS score, and left atrial diameter are comparable between the closed and the Ablate by Law single center study. But here you can see the difference in the procedure. So main difference are related to the efficiency. Procedure time was 155 minutes in the closed, 59 minutes in the Ablate by Law. Fluoroscopy time was 16 minutes in the closed versus 0.7 in the Ablate by Law. Fluoroscopy dose about 11 milligrams square centimeter versus 1.5, and complication rate was 0% in each one of the studies. Here you can see the ablation index needed in closed, in anterior and posterior wall, and needed in the Ablation by Law in the anterior and posterior wall. So in the closed was about 550 and more than 400, as compared with 365 and 342. With respect to close, there was a mean reduction of ablation index applied of 33% in anterior wall and about 1/3 also in the posterior wall, and a mean radiofrequency reduction of about 50%, and maintaining or even improving. We cannot say that because it's not a randomized controlled trial comparing one study versus the other study. But we, during a follow-up of 1 year, 11 plus minus 4 months, we have 95.5% atrial fibrillation free after atrial fibrillation ablation, which is, at least as far as I know, the best results in an atrial fibrillation ablation study communicated until now. So, what is our goal nowadays here in Teknon today? To perform always personalized atrial fibrillation ablation with the goal of doing the procedure with a less than 1 hour duration, less than 1 minute fluoroscopy time, and less than 1 minute complication rate. This is a way to do ablations which is faster, is safer, and is also cheaper. And what is next? What is coming? First, the multi-center ablation by law study that has started already and that will be done here in 2 places in Spain, another one in Italy, in Pisa, and 2 more centers in Germany. One of them is Leipzig, our colleagues from Leipzig, and 2 centers in the United States, one of them in Philadelphia and the other one in Boston. And after that, we will adapt the way of delivering radiofrequency by the Q-dot technology catheter by doing the Q-dot by law study. So in general, the ablation by DO is using the information of imaging, CT scan, before the procedure with the information of the left atrial wall thickness. This will impact the way we tailor radiofrequency delivery. We use also not only the information of the left atrial wall thickness, but also the distance and trajectory from imaging also of the esophagus with respect to the left atrial posterior wall. And we do the procedure with a single catheter strategy. Point 2 and point 3 will impact on safety. And we will use not only the information of the left atrial wall thickness, that is a way of personalization of the procedure, but we use also general anesthesia and high rate low volume ventilation, which is the other way to personalize also the way of doing things in the EP lab for every one of the patients we do. Thank you for your attention. This is my email. If you want, if any one of you can communicate with me, you have here the information, my Twitter account, and here I don't want to finish without showing an image of our first imaging in VTE ablation course that will be probably next year called imaging in EP, because it's an area which is extending, and here is not only used to ablate ventricular tachycardia, but also atrial fibrillation and probably much more substrates. We hope that the next one, I don't know if this year or the next one, could be done also with any one of you here in Teknon. Thank you very much for your attention. And Carlos?
Thank you very much, Dr. Berruezo, for such an interesting presentation. We hope that the next Congress here will be with the presence of our colleagues of the Emirates, of course. We have some questions for you. First one is, when do you think that this software platform will be available to be used in other labs?
This software is already available to be used, and in fact it is used in Europe, in America, in South America, in North America, has the FDA approval, the CE market approval, but the software doesn't have yet the module to be used to guide atrial fibrillation ablation. It's used in many centers to guide interventions in the ventricle, to look out for fibrotic tissue, channels, to guide substrate ablation of ventricular tachycardia, but not yet for atrial fibrillation. We expect that in about 2 years, maybe less, it could be commercially available to be obtained in each one of the centers. First, we have to check not only here in our center, but in a multi-center study, which is currently underway. And I hope about in 1 year, 1.5, maybe 2 as much.
Perfect, thank you. Another one. Do you recommend then starting using general anesthesia for every atrial fibrillation ablation procedure?
For sure, for sure. So even if you do not have the possibility to use this information to tailor radiofrequency ablation at each point, if you go from procedures with conscious sedation to procedures done by general anesthesia, you will improve your outcomes. You will be much more happy in your lab. You will be focused exactly in what you should be focused, which is in managing the catheters, looking different, and not depending on the dose of anesthetic that the patient is taking, and if the patient is stable or not in terms of sedation, if arterial pressure, these kind of things should be taken into account by an anesthesiologist. And this, in addition to the fact that by increasing the catheter stability, if you modify and go from a traditional ventilation to a high frequency, low volume ventilation, you will increase your catheter stability and you will improve outcomes. So absolutely, I recommend that, and you will see what is the big difference with respect to conscious sedation.
Another one question, please. Is there a learning curve needed to set up ablations with GA and left atrial wall thickness information?
There is a very small curve. If you go first to perform procedures to general anesthesia, you will never come back, first thing. If you are accustomed to do that, and you have the necessary setup in your EP lab, then to start using the information of the left atrial wall thickness by obtention of a CT scan before the procedure, that is very easy to implement, will be easy, and to do the ablation. So you have to take into account that we, in our multi-center study, we ask for only 5 cases to prove the way of doing that before starting the multi-center trial.
Fantastic. And the last one question, how much of the low complication rate do you think is due to the use of a single catheter approach?
So if we speak about the vascular access complication, maybe half of the complication rate. So if you decrease from 2 punctures to 1 puncture, you probably will have half of the complications related with the vascular access, despite nowadays is very low if you use echo control to do the puncture. Then you will do AF ablations with a single transeptal access, which is also important. And then you will be manipulating into the left atrium with only 1 catheter instead of 2 catheters. This will reduce the ablation time you need to perform the ablation, and also the fluoroscopy time. And for sure, the complication rate. 2 catheters is, in terms of safety, impact probably as compared with 1 catheter.
Fantastic, awesome. Thank you very much, Dr. Berruezo, for such an interesting presentation. Please, doctors, know that if you have more questions, you can put in contact with Dr. Berruezo and team in the email, Antonio, his name, .berruezo, it's B-E-R-R-U-E-Z-O, antonio.berruezo@quironsalud.es. And the next Quiron Salud Masterclass is going to be presented next Tuesday, the 19th, by Dr. Xavier Ruira, who is the director of the Cardiac Surgery Department in Teknon Medical Center. Thank you very much for your attention. Bye-bye.